Seniors. At the outset, thank you to Pallam Praveen Anna for giving me this opportunity. And all of us know prevention is better than cure. And prevention, actually we are discussing since today morning, etiopathogenesis, anatomy, and diagnosis and investigations regarding fistula and its anatomy. So, right now I am going to the prevention of the fistula in perianal abscess. If not managed properly, up to 30 to 50% abscesses can lead to the fistula in ano. And in other words, if we know the pathology of abscess and fistula, anorectal abscess and fistula in ano are believed to be acute and chronic manifestations of the same disease. So when we are dealing with the abscess, we should know that we are treating abscess along with the fistula. If we think in those terms, we will be handling the abscess in better way so as to prevent fistula in ano. So why does fistula form? So the risk factors for the fistula formation in perianal abscess are patient related, disease related, surgical and surgeon related, anatomy and microbiology. So patient related factors, if we take patient when suffering with immunosuppressive diseases like diabetes, HIV, when patient is on steroids, and when patient is on chronic smoking, smoking causes decreased vascular supply to the tissues. In obesity, there is compromising immunity and poor perianal hygiene of the patient, and malnutrition, anemia. Malnutrition, there will be deficiency of the vitamin A, C, Z in anemia. There is decreased carriage of oxygen to the tissues, delayed healing of the wounds. And disease related factors, if we take location of abscess, that I will be discussing later. Tuberculosis is very common condition in our country. It presents as fistula in abscess, fistula in ano or abscess, perianal abscess. And carcinoma in or around anus or rectus. Inflammatory bowel disease like Crohn's disease or ulcerative colitis can present as perirectal or perianal abscess. They later on can be presented as fistula in ano. Trauma, we will be seeing trauma due to sometimes fishbone abscess we have seen, trauma, foreign body, injury, and hidradenitis suppurativa. And complex abscesses like horseshoe abscess or eye intersphincteric. And recurrent abscesses, patient presenting with recurrent abscesses also can lead to abscess, can lead to fistula in ano if not treated properly. Surgical factors. Surgical factors, these are basically related to the surgeon either in treatment or in diagnosis, like delayed diagnosis or inadequate drainage or inadequate treatment and improper surgical technique by surgeon, and also inadequate post-op follow-up and use of antibiotics alone without treating or without doing surgery. Anatomical and microbiological factors, if we take anatomical factors, perianal abscess, if you take, there are two origins as we were discussing since today morning. One is glandular theory. Anal glands are present in between the internal sphincter and external sphincter, and it opens into the anal colon. So it is more prone to be get infected from the anal canal, anal glands. So by default itself, it is having communication into the anal canal. So there is a chance for fistula formation if inadequately treated or addressed. And resistant organisms, where organisms are not addressed if antibiotics are not properly given. And delayed wound healing. Red flags for early fistula. We have treated anal abscess, and we are thinking that we have given adequate treatment. But when we see these signs, we should contemplate that there will be future chance for fistula formation, like persistent discharge more than 4 weeks, non-healing wound, visible internal opening, and other visible swellings around the opening. How to prevent? Principles of prevention. As I told earlier, early proper diagnosis with good clinical history and along with endoscopic anal ultrasound. As we were discussing since morning, MRI fistulogram or MRI pelvis or perineal area is the gold standard to know the extent of the abscess, or is it associated with any internal opening, or is it associated with any fistula. And while we are doing surgery, we can do sigmoidoscopy or colonoscopy. We can diagnose associated disease like Crohn's disease, inflammatory bowel disease, or any malignancy, intrarectal malignancy, other diseases, so that we can give proper management and judicious use of antibiotics, and identifying treating comorbid conditions, as I told earlier, and even my earlier speakers told that like diabetes, malnutrition, anemia, lymphogranuloma venereum, inflammatory bowel diseases, all other conditions should be detected earlier and they should be addressed. Until unless we treat those things, abscess can lead to the fistula formation, and once we treat, we should follow the patient closely. Surgical tips to prevent fistula formation. While we are treating the abscess, careful examination of the patient under either general anesthesia or in peripheries we will be doing spinal anesthesia, and as I said earlier, we should do, if possible, sigmoidoscopy or colonoscopy, and we should detect any internal opening. Once we have detected there is no internal opening, other things, adequate drainage technique, then we should avoid blind probing. If we do blind probing, you will lead unnecessarily to create a false track, or you will create a fistula track which will lead to fistula formation. We should completely evacuate the pus, breaking down all lacunae, and we should leave wound open. Regarding packing of the abscess, few surgeons say packing should be done, and a few people say packing is not necessary. It is up to the surgeon, depending upon is there any drainage, how he has drained, depending upon his technique. And you should advise to use technique like seton. Seton is mainly used for drainage. If you see there is a internal opening, so as to facilitate drainage of the fistula. Later on you can plan a definitive procedure. And also we should, when you are treating abscess and you know that in the MRI there is a communication into the anal canal or rectum, you can combine a other technique like, as I said, draining technique or draining seton or cutting seton or waft or whatever the technique you feel right and you can do confidently, and you can do it. Follow protocol. Mainly in studies what we observed, the surgeon who has treated the abscess should follow the patient. He should not leave to the patient himself. Regularly he should call the patient to his clinic. He should see that how the wound is healing, and he himself should irrigate, do dressing, and he should counsel the patient regarding the wound management and proper hygiene. And he should look for discharge and new swelling and educate hygiene. And regarding the role of the antibiotics, there is definitely role of antibiotics along with the surgical drainage procedure. If we have given proper antibiotics, there is lesser chance of recurrence. And commonly used antibiotics, amoxiclav, ciprometra, and better results are achieved with antibiotics. And also treat other diseases, as I said, treat diabetes and give medication, IBD or other tuberculosis, and treat anemia or whatever the disease patient is having. Take home message. all of us should know, in any perianal abscess, whenever you are treating, there is definite chance for fistula formation. So, whenever you are treating the patient, you should tell, in future you may get fistula in ano. So that if you get fistula in ano, you come to me and I will give you treatment. There is, don't give assurance that I have given complete cure and there is a chance. But from surgeon point of view, we should identify properly and you should rule out other comorbidity conditions, treat early and give right treatment, use correct technique, and educate the patient regarding hygiene and wound dressings, so that chances of recurrence will be, fistula recurrence will be less. Thank you and one and all, and thank you for Fistula Khan Organizing Committee for giving me this opportunity, and being Usmania student, after 25 years I am standing in stage giving this lecture is a great opportunity for me. Thank you and thank you.